So in this video, we are going to study amenorrhea. We have objective from MCC website. So this is amenorrhea and oligomenorrhea. Amenorrhea and oligomenorrhea are common patient concern. It can associated with potentially serious underlying pathology. Primary amenorrhea is absence of menarche by age 15 in the presence of normal growth and secondary sexual characteristics. Secondary amenorrhea is the absence of menstruation for more than 3 to 6 months. Oligomenorrhea refers to infrequent menstruation, cycle of menstrual period with interval of more than 35 days, infrequent or absent menstruation. In these circumstances is a reason for investigation and management. So what are the causes? Primary and secondary. Primary is central, ovarian and genital tract flow obstruction. If it's central, it is related to hypothalamus. It could be functional, pituitary or ovarian. Ovarian is like ovarian dysgenesis, PCOS, and genital tract outflow obstruction like imperforate hymen. Secondary amenorrhea, oligomenorrhea could be related. Most common causes pregnancy. Then central could be hypothalamus, functional, hypothalamic secondary amenorrhea, which is the most common one, and exogenous hormones. Pituitary prolactinoma, endocrine like thyroid and renal related. Ovarian could be oophorectomy, chemotherapy, PCOS, and uterine related like Asherman syndrome. So what do they want you to know? They want you to know the how to take a complete relevant history, examination, investigation, and rule out pregnancy first. In amenorrhea, a candidate will then differentiate between primary and secondary, and the candidate will initiate an appropriate management plan. So you need to know how to differentiate between primary and secondary, and also appropriate management plan for each one of them. So there's specific management plan on the table in Toronto notes in gynecology. So I'm going to show you that in upcoming in this video. Given the patient with amenorrhea or oligomenorrhea, candidate will list the clinical findings, appropriate history and examination questions, including pelvic examination, investigations that are required, lab investigation, and urological studies, and also construct an initial management plan, including on pregnancy if applicable. If patient is pregnant, what you're going to do on primary amenorrhea if applicable, on secondary amenorrhea other than pregnancy if applicable. Determine whether the patient requires specialized care, counseling, and education as appropriate. So this is the amenorrhea objective that we are gonna cover now. Amenorrhea is the absence of menses due to dysfunction of the hypothalamus, pituitary, ovaries, uterus, or vagina, classified as either amenorrhea, absence of menarche by age 15 and or thereafter, or secondary, which is absence of menses for more than 3 months of women who previously had regular menstrual cycles. So you need to learn the difference between the primary and secondary. Primary is when there's no periods by age 15, and secondary is when there was periods but there's absence of periods for more than 3 months in a woman who previously had regular menstrual cycle. This is from family medicine, but it would be completed once we enter GY7. So let's open GY7, and from there onwards we will be covering amenorrhea. All right, so this is GY5, GY6, and 7. Here we go. All right, so amenorrhea is absence of periods. Now we know primary and secondary. Now there are differential diagnoses for primary. Primary amenorrhea could be with secondary sexual development or without secondary sexual development. So if it's with sexual development, then it could be with normal breast and pelvic development. What could be the reason? Related to hormones. That means if the patient has normal breast development, normal pelvic development, without periods, then what are the causes? It could be related to hormones like hypothyroidism, hyperprolactinemia, PCOS, hypothalamic dysfunction. So 4 different hormones. One is thyroid, second is prolactin, which is high, PCOS, estrogen, progesterone, and then hypothalamic dysfunction. So hypothalamic problem, pituitary problem, regarding prolactinemia, and then hypothyroidism and PCOS. If there is normal breast development but abnormal uterine development, then what could be the cause? It could be related to androgen insensitivity, anatomic abnormalities, Mullerian agenesis, uterovaginal septum imperforate hymen. So these are the causes for normal breast development but abnormal uterine development: androgen insensitivity, anatomic abnormalities, Mullerian agenesis, uterovaginal septum imperforate hymen. This is related to structural abnormalities. Now, if the patient has no secondary sexual development and has high FSH, what could be the cause? Let's say hypergonadotrophic hypogonadism. That means gonadotrophic hormones are high but low hypogonadism. So let's see. Gonadal dysgenesis like abnormal sex chromosomes, Turner syndrome. The chromosome genome is XO, and normal sex chromosome 46 either XX or 46 XY. Okay. Now, with low FSH, hypogonadotrophic hypogonadism, that could be with constitutional delay, rare in girls, congenital abnormalities, isolated GnRH deficiencies, pituitary failure like Kalman syndrome, head injury, pituitary adenoma, acquired endocrine disorders, type 1 diabetes, pituitary tumors, systemic disorders like IBD, autoimmune related disorders, functional hypothalamic amenorrhea, Asherman syndrome, and uterine defects. So this is with low FSH. So you need to divide primary amenorrhea into with sexual characteristics or without sexual. If it's with, then with normal development of the breast and pelvic development, endocrine related causes. If with normal breast but abnormal uterine development, then structural defect like androgen insensitivity or anatomic abnormalities like Mullerian agenesis, uterovaginal septum, or imperforate hymen. And if it's without sexual secondary sexual characteristics, that means there's problem with FSH. Either FSH is low or either FSH is high. If FSH is high, then it could be gonadal dysgenesis, abnormal sex chromosomes, Turner syndrome, and normal sex chromosomes like 46XX or 46XY. Or if it is low FSH, then it could be constitutional delay, pituitary Kalman syndrome, everything mostly related to pituitary tumor, pituitary failure, acquired endocrine disorders, autoimmune disorder, Asherman syndrome. Now here you see primary amenorrhea, no menses by age 13 in the absence of secondary sexual characteristics, or no menses by 15 with secondary sexual characteristic, or no menses after 2 years after thelarchy. So no periods irrespective by 13, irrespective by 15, or after 2 years of thelarchy, but no periods at all. Secondary is for no periods for more than 6 months or 3 cycles after documented menarche. More than 6 months, 3 to 6 months. Okay. Most common causes of primary amenorrhea. Most common one are gonadal dysgenesis, Turner syndrome, functional hypothalamic amenorrhea, and Mullerian agenesis. So remember this. This is important for exam. You need to know the 3 most common causes of primary amenorrhea. So primary amenorrhea, gonadal dysgenesis, Turner syndrome, hypothalamic amenorrhea, or Mullerian agenesis. So these are mostly the structural causes. Okay. So these are most common primary causes of amenorrhea. Now coming to the differential diagnosis of secondary amenorrhea. Secondary amenorrhea is where there is the absence of periods for more than 3 to 6 months. So with hyperandrogenism or without hyperandrogenism. Hyperandrogenism is where increased level of aldosterone. So it could be PCOS, autonomous hyperandrogenism like androgen secretion independent of HPO excess, ovarian tumor, hypertrichosis, androgen secreting tumor, or late onset mild congenital adrenal hyperplasia. So CAH, congenital adrenal hyperplasia, PCOS, hypertrichosis, and androgen insensitivity syndrome. So these are 4 types of hyperandrogenism syndromes. Without hyperandrogenism, pregnancy is the most common cause of secondary amenorrhea without hyperandrogenism. Now, hypergonadotrophic hypogonadism, primary ovarian insufficiency, high FSH, low estradiol. Idiopathic autoimmune like type 1 diabetes mellitus, autoimmune thyroid problems, Addison's disease, hyperprolactinemia, endocrine most commonly hyper or hypothyroidism, hypogonadotrophic gonadism, low FSH, pituitary compression due to pituitary adenoma, craniopharyngiomas, lymphocytic hypophysitis, infiltration, sarcoidosis, head injury, Sheehan syndrome. So these are all secondary causes. Like secondary to all these problems, it could lead to lack of periods. Functional hypothalamic amenorrhea often related to stress, excessive exercise, and anorexia. Now here, functional hypothalamic amenorrhea is the most common cause of secondary amenorrhea. So 2 things that you need to remember. The primary 3 top causes were Mullerian agenesis, gonadal dysgenesis like Turner syndrome, and functional hypothalamic amenorrhea. These are the common causes for primary amenorrhea. The common causes for secondary amenorrhea is hypothalamic amenorrhea is the functional hypothalamic amenorrhea. Now, let's say a patient is coming in with amenorrhea. So you will take the history and you will do the examination. On history examination, the first thing that you want to rule out is if the patient is primary amenorrheic or secondary amenorrheic. If the patient, let's say, is let's say 16-year-old, she never had periods before. Now you will check if she has the secondary sexual characteristic made or no. If yes, like breast and pelvic development are normal, then let's say if they're all normal, yes, then you will do karyotyping. Okay, and in karyotyping you will check for XX, and you'll check for imperforate hymen, transverse vaginal septum, cervical agenesis, Mullerian agenesis. So this is for everyone with secondary sexual characteristic, without secondary sexual characteristics. So you'll check for structural abnormalities, and then you will also look for androgen insensitivity syndrome. Let's say if there's no secondary sexual characteristics, then you'll do FSH and LH. If FSH and LH are high, so that means hypergonadotrophic gonadal agenesis dysgenesis. So hypergonadotrophic situation. But if it's low, then it is hypogonadotrophic. That means a problem in the hypothalamus or pituitary. So that could be constitutional delay or HPO excess abnormalities. So you need to, like, if the patient is coming with primary amenorrhea, you need to either do FSH LH to check for gonadotrophic hormones in the hypothalamus. So if it's high, that means hypergonadotrophic situation, gonadal agenesis, there's a problem in gonads. But if it's a low FSH and LH, that means it is hypogonadotrophic situation where there could be constitutional delay or HPO excess abnormality. But let's say if the patient has normal FSH-LH but they do not have the secondary sexual characteristic properly developed, then you will go for chromosome karyotroping. In karyotyping, you will go and see for imperforate hymen, transverse vaginal septum, cervical agenesis, Mullerian agenesis, and also you look for androgen insensitivity syndrome. So this is the approach to primary amenorrhea. Let's say if a patient is coming in with secondary amenorrhea. So first thing is to rule out pregnancy. If she is not pregnant, so if she's pregnant, then that's confirmed that it is pregnancy. But if she is not pregnant, then you will check her prolactin hormones. So first thing for secondary amenorrhea is beta HCG to rule out pregnancy. Second thing is to look for prolactinemia. So you'll do prolactin levels. If it is high, that means the patient has prolactinemia. Prolactin should be less than 20 nanograms per deciliter. And if it's, let's say, prolactin is high, next step is to do CT. If more than 100 nanogram per deciliter of prolactin, and TSH to screen for hypothyroidism. So two things here. First thing beta HCG, second is prolactin. If prolactin is high, let's say, so you're gonna do prolactin levels along with CT scan to look for any abnormalities, and then also you're gonna do a thyroid test along with prolactin. And then let's say if prolactin is also normal, then you will do is progestin challenge test. In progestin challenge test, you will give progestin and then you'll remove progestin. After removal of progestin, there is no bleeding. So this could be primary ovarian insufficiency, uterine defect, Asherman syndrome, or HPO excess defect. So it could be related to ovaries, it could be related to uterus, it could be related to Asherman syndrome is pituitary, or it could be related to HPO excess, hypothalamus, pituitary, uterus, or primary ovarian insufficiency. So progestin challenge test, no, if no bleeding. And if it bleeds, then you're going to check for LSH, LH and FSH. And in LH and FSH, you're going to see if it's high. Let's say if luteinizing hormone is high, so then you know this is PCOS, hyperandrogenism. But if it's low or normal, then HPO excess problem, MRI for hypothalamus and pituitary, and measure other pituitary hormones. Common etiology: weight loss, excessive exercise, or systemic disease. So these are other more common ones for amenorrhea. So the approach to secondary amenorrhea is very systematic in a very hormonal manner. You do beta HCG, you check for prolactin for hyperprolactinemia, you check for progestin challenge test to check for ovarian insufficiency, uterine defect, and Asherman syndrome, and then you check for FSH and LH. If it's high, then it is PCOS. But if it's low or normal, then it's hypothalamic pituitary axis dysfunction, MRI, or it could be related to weight loss, excessive exercise, or systemic disease. So this is a most important table for amenorrhea. If you are short on time before your exam, just go through these tables and these flowcharts to have a clear cut concept of how you need to approach these. Okay, so this is how they're gonna ask you question. Let's say they would give you a situation in progestin challenge test. They want to know about primary ovarian insufficiency, right? So if you have a clear concept of this chart, you will be able to answer all the questions. Now, what are the investigations? Now we have already done the one on the top, so it's going to be easy. We do beta HCG for secondary amenorrhea, hormonal workup. We check for thyroid along with prolactin, and then we also check for FSH-LH to rule out PCOS. We check for androgen to rule out androgen insensitivity syndrome. We check for estradiol as well. Progesterone challenge test to assess for estrogen status. Medroxyprogesterone acetate Provera 10 milligram per oral once daily for 10 to 14 days. So that's how we do progesterone challenge test, where we give the patient Provera, which is called as Provera or medroxyprogesterone acetate for 10 to 14 days, and then we ask the patient to withdraw medroxyprogesterone acetate for 7 days and see if there's any withdrawal bleeding. If yes, then we need to check for FSH and LH. If there's no withdrawal bleeding, that means the patient has primary ovarian insufficiency. The patient may have uterine defect, Asherman syndrome, HPO excess dysfunction. And any uterine bleed within 2 to 7 days after completion of Provera is considered to be positive withdrawal test. So we do positive withdrawal test. If the patient start bleeding within 2 to 7 days of completion of Provera, is considered positive withdrawal test. Withdrawal bleed suggests presence of adequate estrogen to thicken the endometrium. So withdrawal bleeding suggests presence of adequate estrogen to thicken the endometrium. Thus, withdrawal bleeding of progesterone results in bleeding. Withdrawal of progesterone results in bleeding. If no bleeding occurs, this may be secondary to inadequate estrogen, hypoestrogenism, excessive androgen and progesterone, pregnancy, obstructive causes, example cervical stenosis, structural causes. So if even after withdrawing the progesterone there is no bleeding, then there's some kind of structural defect or hypoestrogenism, or there could be excess androgen, pregnancy, or obstructive causes like cervical stenosis, structural defects like uterine adhesions. Karyotyping indicated if primary ovarian insufficiency or absence puberty. So we do karyotyping if there is no puberty or there is primary ovarian insufficiency. Ultrasound to confirm the normal anatomy, identify PCOS in adult population only. So what is the approach? Mainly we do blood work that includes all the hormones, FSH, LH, prolactin, TSH, androgen, estradiol, beta HCG, all those hormones. We do progesterone challenge test. We withdraw progesterone to see if there's bleeding. If there is bleeding, then this could be lack of progesterone. If there's no bleeding, then this is related to structural defects. And we also do karyotyping in primary ovarian insufficiency and also lack of puberty. And ultrasound is to confirm the anatomy of uterus and also to check for identify PCOS. Prolactinomal symptoms are galactorrhea, visual symptoms, and headache. Any young patient who's coming with galactorrhea, who's coming with visual changes, headache, do consider prolactinemia. Now, treatment of amenorrhea. How would you treat amenorrhea? Let's say if it is so it depends on the cause. Like what is the cause of amenorrhea? If it is related to primary amenorrhea where there is androgen insensitivity syndrome, so you will do is gonadal resection after puberty, psychological counseling, creation of neovagina with dilation. So androgen insensitivity syndrome where there is insensitivity to androgen, you would do is you would resect the gonadal resection after puberty. You will do psychological counseling, most important part, and also you will do is creation of new vagina with dilation. Anatomical imperforate hymen, so you have to do surgical management, transverse vaginal septum, anything surgical structural related, you will do surgical management. Transverse vaginal septum, similarly surgical management. Cervical agenesis, suppression, and ultimately hysterectomy. If there is agenesis of cervix, then suppression and ultimate hysterectomy. Mullerian dysgenesis is also known as MRKH syndrome, psychological counseling, creation of neovagina with dilation. Diagnostic study to confirm normal urinary system and spine. So all these primary amenorrheal causes, you need to do some kind of structural changes, surgical management, or psychological counseling along with that. In the primary amenorrhea. In secondary amenorrhea, it could be related to HPO excess dysfunction. So identify modifiable underlying cause Combine OCPs to decrease risk of osteoporosis, maintain normal vagina and breast development, not proven to work. So in the HPO axis, what you have to do is modify underlying cause, and you have to give OCPs to the patient to reduce the risk of osteoporosis and maintain normal vaginal and breast development. In hyperprolactinemia, you need to do MRI and CT of the head to rule out lesion, and if no demonstrable lesion by MRI, then you gotta do is you will give bromocriptine, gabagoline if fertility desired. Combine COCPs if no fertility is desired. So there are two different kind of management plan for patients with hyperprolactinemia. If patient wants fertility, then you will give gabagoline, bromocriptine. But if the patient does not desire pregnancy, then you can give OCPs. Demonstrable lesion by MRI, structural surgical management. If there is a lesion, then you have to do is surgical management. PCOS, you have to do is OCPs. Premature ovarian failure, screen for diabetes mellitus, hypothyroidism, hypoparathyroidism, hypocortisolism. So this is for premature ovarian failure. If there is ovarian failure, you will look for other hormones as well. Hormonal therapy with estrogen progesterone to decreases the risk of osteoporosis, can use OCPs after induction of puberty. So if there is premature ovarian failure, you will check for other hormones, as well as you will gonna give is estrogen and progesterone to reduce risk of osteoporosis, and can use OCPs after induction of puberty. If there is uterine defect, you have to do is evaluation with hysterosalpingiogram, where they will put dye and camera in the uterus to look for the structure. Asherman syndrome, hysteroscopy, excision of synecdoche. So Asherman syndrome is where there is a fibrous attachment within the uterus, by fibrosis within the uterus. So you need to do is hysteroscopy and excision of synecdoche. Secondary amenorrhea is pregnancy until proven otherwise. So pregnancy is the most common one, and then we know the other common causes of secondary amenorrhea is, here it is, this one. Functional hypothalamic amenorrhea is the most common secondary causes, and the primary one is Mullerian agenesis, functional hypothalamic amenorrhea, and gonadal dysgenesis like Turner syndrome. So this completes amenorrhea, and make sure to cover this table. Make sure to learn this the treatment plan and this flow chart. So this would cover your amenorrhea entirely. I hope you like this video. Please make sure to subscribe the channel and continue following. Thank you and good luck to you.